Welcome to Massey Dialogues. I'm so happy to be here with you today for a great show. We're going to be talking about medical innovation and virtual care. So there could not be a better time to do that. Massey College is the place for ideas. Its mission is to nourish learning and serve the public good. Massey, the physical college, is located on Indigenous land, the land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. We're so grateful for the ability to continue to do our work here. So today we're going to talk about medical innovation, and I'm joined with a great team. Actually, the medical establishment and the professions are coming to Massey, so it's great to have you here virtually. I'll be joined first by Dr. Sacha Bhatia. He is the FM Hill Chair in Health Systems Solutions and the Chief Medical Innovation Officer at Women's College Hospital. He's also the Division Head of Cardiology at WCH and a staff cardiologist at UHN. He's a scientist at the Institute for Clinical Evaluative Sciences, an associate professor at UofT. He's published a lot of things. He was in the press recently. He's received numerous awards, the American College Cardiology's Young Investigator Award, the American Society of Echocardiography Arthur Weeman Young Investigator Award, and most recently, the Goldie Award for Quality and Innovation, and the Louise Lemieux-Charles Emerging Leader Award from the University of Toronto. And he was described to me as being the guru of virtual care. So we're so happy to have you with us today. As you know, Massey Dialogue is based on intergenerational exchange. We are devoted to the idea that to serve the public good, we need to talk among disciplines and among generations. So I'm always very happy to invite our junior fellows to participate. And today I'm so happy to have Krish Bilimoria, who's a first-year resident junior fellow, second-year medical student. He's worked broadly. His research is in genetics, molecular epidemiology, global health impact. He's currently the Vice President Finance of the UofT Medical Society, very important. And he's also just a fabulous member of our community. He's been on Massey Dialogues before. He practices yoga and even Bollywood dance move at times. So welcome. It's so nice to have you with us, Krish. And finally, I think I'm so delighted to be able to welcome her senior fellow, Dr. Katherine Whiteside. She received her medical degree and PhD from University of Toronto. She's a fellow of the Royal College of Physicians in Canada. She was the Dean of Medicine at University of Toronto. She also is widely published, widely recognized. She was recognized most recently as WXN Canada's Most Powerful Women Top 100 Award in 2012. So we know that. And she's such a fabulous person to have on the show because she's the one that thought about bringing on Dr. Bhatia, saying you need him to listen to what he has to say. She's received numerous awards, the Order of Canada, the 2007 Medal for Research Excellence from the Kidney Foundation, the 2009 May Cohen Award for Women Mentors, and she is now doing she's the executive director now of Diabetes Action Canada, a CIHR strategy for patient-oriented research network in diabetes and related complications. Thank you so much, all of you, I know that you're all very busy, so I am extremely grateful that you've come to enlighten us a little bit. So, Dr. Bhatia, I'll start with you. Your entire life was about innovation, changing practices, and virtual care has been the thing that you've been advocating and pushing forward. And COVID, I think, is the example of where virtual care has soared. Can you tell us a little bit about what we're learning from this crisis?
Yeah, thanks, first of all, for having me on, Natalie. This is a really great opportunity to speak to the citizens of Massey So I would say what we're learning is, so I've always been a health policy researcher and a health systems strategist. I almost don't call myself a researcher. Think of myself more as somebody who thinks about strategy. And what I would say is we've been banging our heads on the idea that technology needs to advance in medicine. We need to think about new ways of communicating with our patients that are much more patient-centric. And for a long time, we often think of the fax machine and paper letters and paper charts as endemic, and the pager, which nobody else but doctors really use anymore, as sort of the tools of our profession. But all of that has changed, I think, in the last couple months, because COVID has introduced new risk around physical contact, what I would call the costs of contact into, our interactions with patients, particularly patients that have chronic diseases. These are the ones that are most likely to be, on the one hand, needing our ongoing care and management, those with diabetes, as Dr. Whiteside knows, cardiac disease, and lung disease. But at the same time, they're the ones for whom, if they get COVID, are much more likely to end up with a bad outcome, being on a ventilator, hospitalized, or death. And so this is where virtual care can become the great equalizer, so to speak, or a great tool, because we can provide some of the care that they need, but provided at a distance, which also protects them, protects the providers themselves, and at the same time, other patients that might be sitting in a waiting room with them. So as I've said, it's like the COVID pandemic in some ways was the match that sort of lit the fire around this revolution in virtual care.
And prior to COVID, I think there was the resistance to this because people are a bit afraid of technology. What if my Skype doesn't work when I'm talking the 30 seconds that I have with my doctor, or was it, what was the resistance coming from? Or is it just because doctors have been practicing a certain way and have been trained a certain way for so long?
You know what, I think it's multifactorial. So I think one is exactly as you've suggested. People get used to doing things a certain way, and doctors get used to practicing in a certain manner, and it's very hard to change. There's an inertia. At the same time, there was technology issues. I think people are afraid of using Skype or Zoom or those sorts of questions. There were always concerns about privacy. Can we keep people's data private if we're emailing with our patients, for example? That there were issues around care quality. Is the quality of care going to be the same, doing a video visit versus doing an in-person call? And then there's the question of billing, which has always been the elephant in the room, which is we have a fairly antiquated, or did have a fairly antiquated billing system that said, well, I would get paid only if I saw someone face to face, but a telephone call and email doesn't allow me to bill. And so the good news on that last front is that that's somewhat changed recently. But I think a lot of those factors put together created a tremendous inertia keeping the status quo.
And so, but do you have data now on the quality of care? Like, are you able to reassure a little bit that, or do you know when it's appropriate to do televisit and when it's not, or are we getting more sophisticated, basically?
It's a great question. And the answer is, so just to give you a sense of context, in Canada, probably about 10% or less of all of the visits up until 6 weeks ago were done in person. And I can tell you, looking at data from multiple hospitals, including my own at Women's College, we're now over 70% virtual visits in a number of hospitals. We've seen some cases 780% increases in virtual care because of the pandemic. Yeah. So this has all happened very fast. What we don't know is what the impact of that is going to be. So we don't really have a good sense of whether or not this has shifted the quality of care. whether this has meant that people get better outcomes. So we're actually in the process of starting to study this, using administrative data to begin to understand in a patient with heart failure, say, for example, is in-person care versus virtual care equivalent? Are there differences in the way we practice? And what are the differences in outcomes? But I think there was such a rush for us to do this to protect our patients and providers that I think we've gone quickly, which we should have. But now, if we're going to make it sustainable, we need to do the research to begin to understand what the impact of that has been.
Well, just before I bring in Krish, I just wanted to ask you, because in these dialogues, we've had people from Afghanistan coming and saying, oh, well, Canada was always a leader in virtual care because great distance, and we had to imagine how to serve the North and so on. But I think what you're telling us is, even though we may have been leaders in some things, we had not really scaled up the practice, if I understand.
Yeah, it's a great question. So, the Ontario Telemedicine Network is probably one of the world leaders in delivery of telemedicine services because Ontario is so big geographically, and you literally can't have specialists in some of the areas, in the province. So while on the one hand, we do have good reach to certain rural and geographically remote areas, by and large, the average practice still conducted the majority of its visits in person, unless you had to come from 10 hours away. So the practice, and to be fair to Canada, this is general around the world. There are very few places that have actually been doing virtual care. So Canada has an opportunity here to really be a leader, internationally in understanding the impact of virtual care and changing the care model.
Yes. Well, that's the right time to bring in Krish, who's a medical student. So is it going to change the way in which you learn to practice or medicine, Krish?
Well, I think what I find really interesting out of the COVID pandemic and the transition to virtual care is thinking about how clinical skills and clinical evaluation will change. Something I've been thinking about is how do you evaluate and assess patients virtually, and what kind of skill sets and competencies do we have to learn as learners to make sure that that process can happen sort of in a smooth transitioned way. I think if we go back to some of the barriers that Dr. Bhatia was speaking about to virtual care was some of the reluctance to transition to virtual platforms. And if we can train medical students and residents, my thought might be that transition to that kind of virtual model might be a bit easier. So I think that's something to think about. And another thing to think about that I've been thinking through has been the infrastructure around virtual care. So beyond the actual video conferencing platform, might we need e-prescription platforms or ways in which to validate identity of patients if they're going in for a lab test or other things, and what kinds of identification mechanisms exist and which ones don't yet exist and which ones need to be built.
So interesting questions for you to ask Dr. Bhatia. Do you want to respond to some of his queries? What's the future of innovation? We'll need more engineers, more new models here.
So absolutely, Krish. This is an exciting time, I think, to be a medical student, because never, I think, in our medical history have we seen such a revolutionary change in practice in such a short period of time. So, there was a paper I remember in JAMA a few years ago that talked about this idea of the medical virtualist. So basically, you would have the idea was that there would be only a certain number of folks that would actually need to do virtual care, so we should train them on how to do it. The reality is that now seems a bit outdated, because it seems like every doctor is going to need to know how to do virtual consultation and follow-up with their patients. Everyone is going to need to know, what type of modality to use with their patients and when, just like what type of test or to prescribe on which patient for which condition. So when is a phone call? When is an email? When is a televisit? When do you need to use wearables? and remote patient monitor. So I think this is a time that we don't even know the answers to these questions. So if you're a medical student walking in, the research opportunities are limitless. And then not even to mention the engineering piece, because we're going to need new gadgets, new types of devices, and the analytics, which I know Dr. Whiteside will love to talk about, which is around the big data piece. We're going to have a flood of new data to be analyzed to help better manage our patients with disease. So I think the future is bright for this, and I think medical student involvement at all levels, from education to research, is going to be absolutely critical.
Well, let's bring Dr. Whiteside then. Yes, I'm quite curious about how to study what is the sophistication about when is quality of care improved or not improved. So we'll need data, and that's been part of your work, managing or thinking about the use of big data, particularly for people with diabetes or people that have chronic conditions. Maybe you could tell us a little bit about what you're doing.
Thank you. So our group is the first in Canada to create a national diabetes registry, where we have now over 120,000 patient records from electronic medical record sources in primary care, and an equal number of individuals, their data, who are not diabetic. And this is a great resource for us for studying exactly the questions that you're raising. What does quality of care look like? What are some of the innovations that we need, including access to handheld devices, monitoring systems, and how the data interconnects? One of the big challenges is the ability for patients to have access to their own data, and for the same data to be shared among their circle of care. So we're very engaged in this, and as Sacha mentioned, one of the key issues is around privacy. And we know that a number of the provinces are opening up their privacy legislation, including in Ontario, so that we're beginning to see opportunities for changes in regulation so that access to data can be more patient-centric, as opposed to the kind of regulations that we've been experiencing that have limited access to data. I'd like to go back, though, for a moment to talk about what's happening in Canada with regard to the recommendations around training of physicians. So literally at the end of April, the Royal College of Physicians and Surgeons in Canada issued a report on artificial intelligence and digital technology. And the recommendation was that we start training physicians in advanced technology techniques to be able to use them in clinical practice, as well as to be able to train individuals for research, as Sacha mentioned. And I agree with him. This is really an exciting time. This area is moving forward very quickly, and we have tremendous resources in Canada now for training. For instance, in artificial intelligence, we've got 3 major centers in Canada, in Toronto, Montreal, and in Edmonton. And so to be able to integrate education and clinical training in this environment, I think Canada can really step forward in the future. And again, some of the work that we're doing in our research consortium relates to this.
But essentially, I think what you're using the data for research purposes, but that should lead eventually to using the data for sharing the information with a range of care providers, and so people consent to that, or so that the model that you have, the people that signed up and clicked that they consented to their information, or was it a little bit more difficult than that to put together?
Well, that's the goal. Mm-hmm. And one of our handheld devices called Bant, mm-hmm. after Frederick Banting, it's in development for exactly that kind of consent through a handheld device, just like you would consent for your financial work with your bank, for instance. But that will require some further negotiation with privacy commissioners, but we're in the midst of doing that. I'd like to get back to the question you asked, though. What is the relationship between access to data for research versus access to data for patient care? And this is one of the big challenges, and I'd love to hear Sacha's comments about this.
Yes.
That's a great question. And, for a long time, as Dr. Whiteside knows, in Ontario, a lot of our registries and a lot of our patient portals, so to speak, were allowed to be used for what they called patient care only, and secondary use was excluded. And I actually think this is very problematic. And the reason being is, when you think about secondary use encompasses a number of things. It can go from everything from academic research, but all the way to things like quality improvement and system improvement. And so, when they talk about primary use, they talk about, well, only use it to treat the patient in front of you. But if you're, for example, running a clinic or running a hospital program of, say, cardiac patients, and you don't know, for example, that your readmission rate is 2 times the provincial average, well, that's actually that's having an impact on patient care. And so, nowadays, and when you think about COVID, is a great example of where research and practice are effectively happening in real time. So using research will actively help develop new treatments and new approaches that will potentially save lives, not in 6-7 years from now, but literally next month. So I think we have to take a much more pragmatic approach to the way that we think about data and privacy. And I think some of that involves engaging the public in a conversation around where they see the best use of their data, for public good. And I think a lot of the times we don't ask the public and have an honest conversation about the risks and benefits to their privacy are. And I bet you at this time, if you had a conversation with the public about, would you want my data being used to develop new treatments to protect people from COVID or to treat COVID, they might actually have a very different response than they might have previously.
Well, that's true, and obviously because I come more from the legal background, we always worried about hacking. We always worry about the fact that the information could be used for nefarious purposes or by someone who has access to it and uses it to look at what his ex-boyfriend, ex-girlfriend is doing, and so on. So it's interesting that the privacy commissioners have always talked about privacy by design, which is include the concept or the idea of privacy as you design your model, so that you're not at the end asking that question to the consumer: do you choose life or privacy? That's an unfair choice to ask. But I want to bring as well. I think we talked earlier about the fact that this is a great opportunity, great time to reflect on the move from big data research to big data helping develop models of care. It's also a time to think about international cooperation. I think we see that as someone who's not in the medical field, it seems like we're hearing more about that now. Is that something that you see currently and as you're developing these new practices? Let's start with Dr. Whiteside.
Yes, for sure. Our group has a number of important international collaborations with the UK, with Australia, with the US. And what we're learning is that the issues are similar, but the solutions can be customized based on, again, privacy legislation, as well as systems So, for instance, in the UK, the primary care data system is all networked, and access to primary care data can be downloaded on a daily basis for analysis. They're doing this now. In fact, there's a research group at Oxford that we're collaborating with they're downloading data every day to analyze what's happening in primary care around COVID. We'd like to be able to do that here in Canada. And in fact, the good news is that the EMR vendors that we're working with have now enabled us to start downloading data rapidly, even on a daily basis. This is a huge step forward for us and a model that we're trying to emulate from the UK. So the international connections are very important. And again, if you want big data, it's been very hard to get at enough Canadian data for our artificial intelligence scientists to actually utilize. And maybe Sacha would like to comment on the recent announcement in Ontario about the pandemic threat response, a new system of data connectivity that we're going to see emerge as early as June.
Oh, wow.
Sacha, do you want to talk a little about that?
Sure. So as one of the things that's little known about Ontario and Canada is we do have, pretty world-class expertise in data analytics as it pertains to the use of administrative data, so billing data or claims data. And this is in Ontario, much of it is at the Institute for Clinical Evaluative Sciences. What we're hoping, with this new initiative called Panther, and the details are just being rolled out, is there'll be much more real-time engagement of, this data set for COVID-positive patients. So we'll be able to do analysis in real time around the impact, around some of the clinical features of COVID and some of the, potential outcomes for patients who develop COVID, and really being able to describe it. And I think this is really important, because as we know, as we're starting to understand with this disease, it not only affects different people who have different medical conditions differently, but it also affects different socioeconomic groups differently. It's affecting people with different geographies differently. So, we're hearing it may have different gender differences in terms of its impact. And so really beginning to understand the patient populations beyond, their medical history, but something a bit more complicated and robust is going to be really important when we start to develop strategies for how to, treat people, or even more upstream, prevent certain groups from getting, this virus. So I think big data analytics can help to inform strategies. We're hoping in much more real time to be able to protect people, who are currently not infected from getting infected.
So, Chris, let me hear from you. I mean, you're interested in health improvement generally. I think that's one of your areas of research. Any reflections on any questions to our two experts here?
Well, I would start with a number of reflections first. I think, at least on the data side and the importance of open data and analytics, I know there's a number of medical students on a team led by Dr. Ben Fine called How's My Flattening? And they've been a multi-sectorial collaboration among people in industry, clinicians, as well as data scientists, and actually open medical students and computer science students to really evaluate cleaned data from public health units about COVID positive cases and where they are geographically in Ontario. So I think some of that work has been done at a grassroots level. And I think I've been noticing a difference in cultures and how research is done and operated, at least from my colleagues in engineering. Much of the work is done quite openly with their code published completely on a repository online with people who can scrutinize the underlying data set and the code in real time. And I think we're seeing more of that as a different culture enters into the analytics space that's traditionally occupied by health researchers, and there's an opportunity for more open collaboration that way. So I think that there's some work being done there, but it'd be nice to see that culture continue to change and evolve in the course of the pandemic. I think one question I have is, what do you see are the biggest barriers to this balance between openness in data as well as ensuring data privacy, especially for health data? Because I think that's been a discussion point that a lot of people in the engineering computer science space have struggled with in trying to access health information compared to things like Uber data or other data sets.
Right. Well, I guess, one of the things I might say is, looking at the one is the question that there's always been two questions, and I'm not the privacy expert, but some of it is there is quite a bit of fragmentation around the data. So remember, there's, we have claims data provincially, and there are repositories of data, but a lot of data doesn't sit in one central place. Every hospital, every doctor's office has snippets of data, and some of it's shared and some of it's not shared. And the other thing that we should, and then not even to mention the non-healthcare related data, which sort of sits in a various number of silos. So first off, not all the data is in one place. So there's not ubiquitous data. There's silos of data. But then the other thing is, a lot of it is the interpretation of the legislation around privacy. So you talk to 10 different privacy experts and you get 10 different opinions about the risk of sharing data and about with whom you can share the data with. And so I think some of it might be the legislation. And I know this government before the COVID pandemic was even looking at PHIPAA in a more robust way to think about how it could be modernized. And they mentioned this publicly. But also, there's an interpretation question, which is how do you ensure consistency in how the legislation is interpreted to, kind of strike that balance. And I think every hospital in Ontario sort of interprets it slightly differently.
Well, that wouldn't be the first time that there would be some differences in interpretation, but it is an issue about the way in which you move to, and different cultures are risk adverse in terms of wanting to take risk on data. I'm continue to be really intrigued by virtual care myself. I have to say, I think I see how it's going to be the future, how I see how patients will love it, will want it. What's the downside? What are the fear that you have when you're going and developing that areas? Go ahead, Dr. Bhatia, and then I'll do a tour around our virtual table.
Yeah, sure. So there's a lot of unanswered questions yet about virtual care, and part of it is like anything in medicine, we often have standards of practice. What's a standard, and Krish will know this, standard physical examination. There's a certain way that you go about doing, there's an order to it. Virtual care, we haven't, a lot of those standards of practice have not yet been fully developed or flushed out yet. So what is the appropriate information that you can get? So there are a lot of conditions for which we're kind of making it up as we go, to be perfectly honest, as the pandemic has hit. Secondly, there's a question around impact, both on the downstream utilization and on outcomes. So what I mean by that is this. There's some literature that's conflicting that suggests that a virtual visit will lead to both overuse of some services or underuse of other services. So here's an example. And I had this with one of my patients. So I had a patient in my office who was complaining, I wasn't in my office. They were virtually at their home, and I was doing a phone call with them. But they were saying that they felt a little bit short of breath, but I couldn't examine the patient because they weren't physically in my office. So I sent them for a chest x-ray. So that's an example of maybe if in different circumstances, I might have been able to examine the lungs and made a decision. On the other hand, there are certainly instances where we scrutinize in much more substantive ways sending a patient in to get a test, whether it be lab work or an imaging test, because we don't want to have we don't want them to get in contact unnecessarily and put them at risk of coming in unnecessary contact with the healthcare system, which might lead to unintended underuse of needed tests. So then we miss things. Yeah. So, and all of that to say, what we don't then know is, does virtual care, particularly in vulnerable people with chronic diseases, lead to differences in outcome? So on the one hand, we might think, well, this is actually great. We can give them more care because we can do care in their home, and they're probably more comfortable. We can monitor them. But does that necessarily lead to ultimately more emergency room visits or hospitalizations or God forbid, mortality? We just don't know the answer to that yet. And so that's sort of the work that we want to do now, is really understand the impact.
So, Krish, do you think that there'll be a different generations, a generational impact? I can imagine that your colleagues will be quite familiar and quite comfortable with using technology to do much of their practice, since that's the way they live a little bit. So is that going to be easier for you to adapt to that type of practice?
Well, I think that's a great question. But I think going back to Dr. Bhatia's point, I think very much the standards for doing that work, at least at my level, aren't very clear yet. So I think there's a lot of work that still needs to be done in developing what the standard exam is for virtual care. At my level, I'm still trying to understand the standard of care for the physical exam when there's a person in front of me. But when we get to a point where the virtual starts being taught in tandem with the physical, maybe we'll get to a point where people are more comfortable. I would say the comfort probably comes in the comfortness with the platforms that might be used to video conference, and the ways in which that generations like ours probably interact with technology. But I think a lot of work definitely needs to be done in identifying how that entire algorithm changes. If you can't listen to somebody's heart or lungs, do you have to order a test to have an idea of what might be there? Or how does that sort of flow of actions change, I guess? And I think that thinking needs to be done first before I think anybody builds further comfort, at least from a trainee level.
So, Dr. Whiteside, you were a dean. I was a dean too. So we're always concerned when you're a dean as to whether you're teaching at the right level, not just for today, but for the future. So was there some reflection way back when about the needed transformation of our healthcare and how it was going to impact medical education? And how come we're so far behind would be my question a little bit.
Well, that's a bit of a complicated question. As a former dean, you likely know that our medical school and postgraduate training systems are highly regulated and accredited. Mm-hmm. And that sort of drives the goals of education to some extent. What we really need is serious innovation in these curricula and how we train health professionals. We've made a lot of inroads. I would say the interprofessional practice that we see today is at a much higher level and more comprehensive level than we've seen before. But we really need to take another leap forward. First of all, in the use of technology. So if Dr. Bhatia has a cardiac patient at home that could be monitored for blood pressure, heart rate, ECG, maybe even auscultating the chest at home, he would be helped to enable virtual care in a way that would be much more successful than what he's able to do today. Furthermore, some of the best examples of virtual care is actually team care. And that's no different than family healthcare teams or teams of specialist services that really focus in on what matters most to the patient, what their needs are particularly, and to customize the approach to care that will enable them to have better outcomes. One of the a very good example of this in Ontario is a smoking cessation program out of the Centre for Addiction and Mental Health, where individuals enter a portal system that's secure. The data are secure. Their information is managed by a coach who triages their needs to a team of specialist people, physical therapists, psychologists, whoever they need. And actually, the Ministry of Health now pays for this program. It's been highly successful. It interfaces with 300 primary care sites in Ontario. And so that kind of approach, I think, is one that we need to both study and build on for the needs of complex chronic disease folks, not just in Ontario. It's something that could be spread and scaled across Canada, but it requires standardization of practice and outcome measures.
Well, we have a question from our audience. I should remind the audience that if you want to ask a question of our specialist, just write it on YouTube on the left-hand side. So I have a question from Gary Mooney. Where does Canada stand in relation to comparable global players in virtual care? What must we commit to do in order to catch up if we're behind? I think you're muted. Got it. Okay, sorry.
I think Canada is actually probably lagged a bit behind some of the leading countries. Places like Denmark have been providing email consultation to their patients for some time. There have been other countries where, actually the developing world has done a very good job of using text message and email to communicate with their patients. But by and large, a lot of countries were still in the phase of predominantly in-person consultations. But this is changing very fast. So I kind of feel like all bets are off right now. To be frank, China during the COVID pandemic moved to almost 50% or more virtual assessment throughout the pandemic. And we were, at the time, thought this was something that was unachievable. But now in Canada, as I mentioned, in many places, we're achieving that at 70% levels of virtual care in many of our ambulatory clinics. So this idea that it's not possible is not true. And I can't help but wonder that Canada has an opportunity to sort of go from worst to first.
Mm-hmm. Well, particularly since for us, because of the large geography, there's so much incentives to continue to develop in this area to ensure equality of outcomes or care throughout the nation. Are there some issues about the way in which the patient will relate through technology? Have you seen that recently? Are there people that just can't do the technology? I mean, I know some people in the Massey community that just can't get on it, can get on the website. So is that an issue about not only teaching the patient how to relate to the healthcare provider, but also to manage the technology?
It's definitely a gap.
Mm-hmm.
I have colleagues who indicate that they have a very difficult time trying to connect with their patient population. So even though we've instituted virtual care quickly, it's not comprehensive. There are a lot of folks who are not receiving care virtually or in any other way today. But I think the older individuals who have complex disease, unless they're coached and supported to engage in virtual care, it's very difficult just to plop them into a virtual care environment and expect it's going to work very well. So there are certainly downsides of having to initiate virtual care so quickly. And again, it comes back to standardization and understanding exactly what the patient needs.
I would agree. So I think it's a complicated answer because I think there's there's sort of two conversations. One is, I think in general, particularly older patients, there's this feeling, and I think it really is a little bit of a misnomer that older patients won't do virtual care. And I think that's actually not true. My mom WhatsApps with me, and she's and my dad WhatsApps with me. The reality is that I did a talk once in Niagara at a retirement educational session with 400 retirees, and I asked them, how many of you have a smartphone? And every single one of them put up their hand. So they're using technology, and I think we shouldn't assume that they can't. But so I would say, and the patients that I've done virtual care with, particularly at this time, really appreciate not having to go into hospital, but still connecting with people. But I think Dr. Whiteside brings up a really important point, which is a question around equitable distribution. Yeah. So one of the groups of people that are not getting probably the same level of care are people who are disadvantaged either technologically, socioeconomically, linguistically, vulnerable groups. Yeah. So, if English isn't your first language, if you don't have a computer in your house, if you, are, for example, in a vulnerable group who may be precariously housed, our ability to connect with you becomes even more suspect. And if you don't have a reliable internet connection as well. So these relate to issues around inequitable access, which has got to be something that, again, we get concerned about. And now it all starts to come together, because if you think about what I said earlier about COVID affecting marginalized groups more so, if now we're also adding in the layer that those groups have a harder time accessing care, particularly virtually, we're now creating a setup for real trouble. So we have to think about equity, I think, in all of this. And there have been some good examples, like, for example, TELUS has given away tablets and phones to people who are underserved, who may not have those devices, with basic plans.
Mm-hmm. Yeah, we're losing you.
I think we need to be more thoughtful as we build these programs around equity.
Well, you're probably right. We used to have the digital divide, where there would be some people that are able to adapt to new changes and new technology. It's not necessarily age. It can be all sorts of issues, economic access to it. So, Chris, what does it tell you for the future of your research plans and the future of your practice? We're coming to the end of our hour here, so I'm going to ask you to make some concluding remarks.
Absolutely. I think what I find most interesting from this is thinking through what it means to practice virtually and being thoughtful about how the system is going to have to be structured, thinking about how we are going to have to change our own ways of examining patients and our own ways of using technology to enhance care. But also going back to the points that Dr. Bhatia made earlier about the concerns around equity. I think equity is an incredibly important thing to consider when we think about transitioning to virtual care, particularly with the digital divide, particularly with whether virtual care is able to connect with people that are socioeconomically disadvantaged or vulnerable. I think vulnerable groups in society, I guess, tend to have to access care at least in ways that have physical providers in hand and may not necessarily have access to the technological requirements to support virtual care. So thinking through those things is going to be important. And I think for me as a up-and-coming medical student and someone interested in building a research career is thinking through these kind of bigger systemic issues, but also thinking through these smaller issues with providing care to a patient. So I think that it's an exciting time, and there's a lot of work to still be done, particularly as the pandemic forces us to think about these questions. So I'm excited to think through how we navigate this space together and how there's opportunities to improve care for all of our patients.
Dr. Whiteside.
Well, one group we haven't talked about in terms of real stakeholder engagement are policy decision makers. And I think the health professions are amiss if they don't try to work very closely with our government and health authority policy decision makers in all of aspects of healthcare, both research and quality improvement initiatives. And I think COVID is enabling us to actually get closer to that kind of productive and positive relationship that we really need to move the agenda forward for access to data, engagement of patients and their caregivers in decision making, and really enable this crisis to be something that we can look back on and say we really leapt forward in the ability to create the virtual care environment successfully.
And Dr. Bhatia, what are your concluding remarks about what to look forward in the next few months and the next few years,
Yeah, I think, COVID has in some ways reinforced our notions around the strengths of our healthcare system and exposed some of the weaknesses. And I think, we can see our hospital systems have been strong. Our challenges around managing chronic disease and frailty have been more challenged, particularly in institutions like long-term care homes and where people are struggling. And the question around the long-term sustainability and capacity in our healthcare system as this crisis moves on forces us to change our thinking. And virtual care provides an opportunity as a tool, not as the end in and of itself, but a tool to help us look at ways that we can provide care differently, not more or less, but differently. To basically be able to reinforce the areas that are weak and hopefully be able to continue to gird and strengthen the areas where we have strength in. And hopefully, I think, use this crisis as an opportunity to really be able to drive our healthcare system into the 21st century that's a lot more patient-centric and is a lot more friendly and high-performing for all Canadians, and all Canadians being the key word. So I'm really hopeful, and I'm hopeful with folks like Krish as well, will be the future of our medical workforce, that we're going to be in good shape.
Well, thank you. Actually, it was, encouraging to think about how we're learning from COVID. We're learning about new strengths in our society, exposing weaknesses, but thinking about solutions that may help us in the future. So I hope that you're going to come back on Massey Dialogues and have good research to let us know how this new form of patient relationships are established, and view it presumably in interdisciplinary way as well. So that's really fascinating. So I want to thank you. I know you kind of took time from such a busy time for all of you. So merci beaucoup. Thank you so much for being here. And thank you to the audience for being here. And thank you to Matt and Abra, who are staff at Massey that helps us do that every day. Tomorrow, we're going to also talk about COVID and learning about the lessons learned from COVID in a completely different area in terms of innovation, corporate governance, and the way in which our society is managing its relationship. And so we're going to continue to send your ideas and your issues, and we're looking forward to hearing from you. Merci. Thank you.